mic.
All right, ready? Hello everyone, my name is Dr. Eric Wamwell. I am a clinical assistant professor with UMKC School of Pharmacy, as well as a clinical pharmacy specialist at Centerpoint Medical Center. Today we're going to be discussing a couple of new antibiotics that have been approved for acute bacterial skin and soft tissue infections. They're lipoglycopeptides. I have here Aaron Herman as well as Kinsey Maxwell, who are both pharmacy students with UMKC's Pharmacy School, to really help us discuss these two new antibiotics that were approved in 2014 as a part of the GAIN Act, which is Generating Antibiotic Incentives Now. This is a part of the 2020 program, which is aimed at getting 20 new antibiotics, or the 10 by 20 program, which is aimed at getting 10 new antibiotics to market by the year 2020. So these are two of those antibiotics that were approved this past year. Lipoglycopeptides are related to glycopeptides like vancomycin. So the reason that we're seeing these antibiotics come forward is that what we know about vancomycin is that there are some toxicities associated with it, namely nephrotoxicity, as well as trough monitoring that comes with vancomycin that can be time cumbersome as well as expense laden, and it's hard to continue these IV vancomycin as an outpatient when you require trough monitoring. Additionally, there's the concern with hetero vancomycin intermediate susceptible Staph aureus, or H-Visa, as well as Visa, where we can see some vancomycin failure at susceptible MICs, and so that's really stimulated some research into some agents that would cover these vancomycin-resistant staph or give some alternatives to MRSA. So the first one that we're going to discuss today is the most recently approved, which is Oritavancin, and Kinsey's going to tell us a little bit about this one, right?
Dalbavancin.
Dalbavancin. So that was the oldest one.
Yeah.
That was the first one approved out of these two. So Dalbavancin. Okay.
Dalbavancin is a lipoglycopeptide. It has the added lipid groups compared to the glycopeptide vancomycin, and these lipid groups improve its antimicrobial potency and its pharmacokinetics, while still preserving its binding site activity. Dalbavancin exerts its antimicrobial effects by binding to the terminal D-alanine residues in bacterial cell walls. This inhibits transglycosylation and transpeptidation of the bacterial cell wall that ultimately leads to growth inhibition. It's thought that these added lipid groups serve as membrane anchors that allow for the enhanced binding and the prolonged half-life. Dalbavancin has activity against gram-positive bacteria, including Staphylococcus aureus and MRSA. Also Streptococcus pyogenes, Streptococcus agalactiae, and Streptococcus aeruginosus groups. There has also been data in vitro on its activity against Enterococcus, except for the vancomycin-resistant Enterococca of the VAN-A genotype. This gene allows the bacteria to alter their terminal sequence from the D-alanine to the D-alanine D-lactate. So then the dalbavancin can't bind to this. Because this VAN-A gene is the same mechanism by which vancomycin-resistant Staph aureus developed, it's presumable that dalbavancin would also have reduced activity against bursa as well. Dalbavancin has been FDA approved for acute bacterial skin and skin structure infections caused by susceptible gram-positive bacteria. The recommended dosing is a two-dose regimen. It's 1 gram IV on day 1, followed by 500 milligrams on day 8. The half-life is approximately 180 hours, which is about 7.5 days. In patients with renal impairment whose creatinine clearance is less than 30 and who are not receiving regularly scheduled hemodialysis, the two-dose regimen is 750 milligrams on day 1 and 375 on day 8. There's no adjustments for patients that regularly are receiving dialysis. This dosage adjustment is because approximately 30% of dalbavancin is excreted by the kidneys. There's no dose adjustments in mild to moderate hepatic impairment. However, in severe hepatic impairment, there's no dosage adjustment recommendations for that, so it should be avoided. There's also no dose adjustments in the elderly populations. When dalbavancin is being prepared for administration, it must be diluted with 5% dextrose. It can't be co-infused with any other medications or electrolytes. Saline-based solutions may cause precipitation if given at the same time as the dalbavancin. And then if you're using a common IV line, you must flush the line before and after administering the dalbavancin with the D5W. Some common side effects with dalbavancin are nausea, headache, and diarrhea. Some more serious side effects include hypersensitivity reactions, infusion-related reactions, reversible elevations in the ALT levels, and C. diff-associated diarrhea. No clinical drug-drug interactions have been studied with dalbavancin, but there is minimal potential drug-drug interactions involving the CYP450 substrates, since dalbavancin is not an inducer, inhibitor, or a substrate of CYP450 enzymes. So in a phase 3 trial, dalbavancin was compared, the 2-dose regimen of dalbavancin was compared to vancomycin IV for at least 3 days, with the option to switch to oral linezolid to complete the full 10 to 14 days of therapy. This consists of 2 identical controlled trials for the treatment of acute bacterial skin and skin structure infections. The intent to treat population consisted of 1,312 patients. All eligible patients were required to have at least 3 days of IV therapy and 1 or more signs of systemic infection. The primary endpoints were measured 48 to 72 hours after therapy, and a successful outcome was defined as the cessation of the spread of the erythema associated with infection and a temperature of 37.6 or lower at 3 consecutive readings at least 6 hours apart. So, in combined, both trials in the dalbavancin group, 525 out of the 659 patients, or 79.7%, achieved a clinical response 48 to 72 hours after therapy, compared to the vancomycin linezolid group, 521 out of 653, or 79.8%, achieved a clinical response. Also, in a pre-specified sensitivity analysis, dalbavancin and vancomycin linezolid had similar success rates with respect to a reduction in the size of the infected area, at least 20% in the first 48 to 72 hours. There was 88.6 in the dalbavancin group and 88.1 in the vancomycin linezolid group. Also, among patients who had bacteremia at baseline, who also had follow-up cultures obtained, 100% of the patients in the dalbavancin group and 85.7% in the vancomycin linezolid group had negative blood cultures at the end of therapy. Adverse events during the treatment were followed up at a 70-day visit to assess if the prolonged half-life would cause a delayed onset in side effects seen. But the adverse events were infrequent and similar between both treatment groups. So the most common side effects seen were nausea, diarrhea, and headache. Infusion site-related reactions were seen in some patients, but the majority of these seen in the dalbavancin group were on days they weren't receiving active drug infusions, they were just receiving the placebo infusions when the vancomycin patients were receiving theirs as well. So it wasn't necessarily due to the active drug. It could possibly be due to the indwelling catheter that caused that infusion site reaction. So in that trial, they showed the non-inferiority of dalbavancin once weekly compared with vancomycin linezolid twice daily for the treatment of acute bacterial skin and skin structure infections in seriously ill patients. In another phase 3 randomized double-blind study, once weekly dalbavancin was compared to twice daily linezolid for the treatment of skin and skin structure infections. Eligible patients were those with complicated skin and skin structure infections involving deeper soft tissue or required surgical intervention, or also had known or suspected MRSA infection. They were also required to have at least 2 local signs and symptoms and 2 systemic signs of infection. The patients were assessed at baseline, day 4, day 8, and the end of therapy and a test of cure, which end of therapy was within 3 days of completion, and the test of cure was 14 days after completion of therapy. So at the end of treatment, 92.3% in the Dalbavancin group and 94.2% in the linezolid group achieved clinical success. Among patients assessed at the test of cure visit, 88.9% in the Dalbavancin group and 91.2% in the linezolid group achieved clinical success. In a microbiological efficacy endpoint, Dalbavancin and linezolid both eradicated at least 85% of their baseline pathogens at both end of treatment and test of cure. MRSA eradication rates were 91% in the Dalbavancin group and 89% in the linezolid group. So overall success rates were similar between each treatment group. Adverse events generally were mild to moderate and comparable between groups. Most common were nausea, diarrhea, headache, vomiting, and rash. There was some infusion-related reactions, but they were both occurred low in both treatment groups. So, in summary, Dalbavancin was seen as well-tolerated and effective medication in the treatment of skin and skin structure infections, including infections involving MRSA. There's also been a phase 2 trial that looked at the efficacy of Dalbavancin in catheter-related bloodstream infections. It looked at 75 patients compared a weekly regimen of Dalbavancin to vancomycin administered twice daily for 14 days. Gram-positive bacteria in the study included coagulase-negative Staphylococcus and Staphylococcus aureus, including MRSA. Patients receiving Dalbavancin had an overall success rate of 87% compared to vancomycin with 50%. This shows promise in a new area that Dalbavancin can be used, and further studies warranted to determine its effectiveness in bacteremia. Some downfalls to Dalbavancin is the inability to de-escalate therapy if it's used as empiric treatment, and this could lead to the development of resistance at a higher rate. Also, the high cost of Dalbavancin will limit its use. A 500 milligram dose is $1,500, so a total antibiotic course would be around $4,500. Some positives about Dalbavancin are the less frequent dosing and lower total dosages in the treatment of serious bacterial infections are important potential benefits. Also, the extended half-life may facilitate a reduction of resource-intensive therapeutics in hospital settings and also promote outpatient or skilled nursing facility treatment. Also, this will reduce the need for indwelling catheter devices in patients as well, since they can just come in for 1 infusion per week. So that's all I have on Dalbavancin.
So it sounds like definitely something that's effective against acute bacterial skin and soft tissue infections when compared to vancomycin, equally effective, 80% for initial response there measured at 48 to 72 hours where there wasn't any progression of the lesion itself. And main downfalls being inability to de-escalate. However, it's only the 2 dose for a 14-day course, and some initial information on bacteremias, which would really be a substantial improvement to the repetitive daily dosing, twice daily dosing, 2 times a day dosing of vancomycin for bacteremias where you need the sustained IV therapy. Okay, very good, great. Thank you, Kinsey. Now, Aaron, you're going to tell us, now we're going to hear about Oritavancin.
Now we will hear about Oritavancin.
Okay, say, all right, let's have it.
Okay, Oritavancin is a lipoglycopeptide also approved for the treatment of acute bacterial skin and skin structure infections caused by gram-positive bacteria. Its mechanism of action is the inhibition of cell wall synthesis by binding to the D-alanine terminus of the peptidoglycan chain and to the pentaglycine bridge, inhibiting transglycosylation and transpeptidation. This cell wall disruption leads to depolarization, increased permeability, and cell death. Unlike other glycopeptides, Oritavancin can bind to deoxypeptides such as D-alanyl D-lactate, which allows it to target organisms with vancomycin A type resistance. It has the ability to dimerize as well, which allows it to bind to bacterial cell walls very strongly. And it also has a side chain that directly disrupts the membrane, which contributes to Oritavancin rapid bactericidal activity. It is hoped that Oritavancin has a low risk of resistance due to its multifaceted mechanism of action. Its dose is 1,200 milligrams IV one time, just a one-time dose, and that dose is roughly $3,000. So it's also pricey. IV Oritavancin is about 85% bound to plasma proteins. It has a terminal half-life of 10 days, so its half-life is longer than Dalbavancin, which is why it is only dosed once. Oritavancin bactericidal activity is concentration dependent, and in vitro, Oritavancin has shown to be more rapidly bactericidal versus MSSA and MRSA than daptomycin, linezolid, and vancomycin. Also, its spectrum activity is similar to vancomycin, but with MICs 2 to 8 times lower than vancomycin. These lower MICs may prove Oritavancin to be useful in vancomycin-resistant pathogens. And again, it has shown activity versus strep, MSSA, MRSA, and enterococcus, whether it's vancomycin susceptible or vancomycin resistant. One phase 3 trial pitted the daily dosing of Oritavancin. Before they determined that they wanted to do a one-time dose, they were looking at it given daily in either 1.5 mg per kg dose or 3 mg per kg dose versus twice daily dosing of vancomycin for 3 to 7 days in the treatment of skin and skin structure infections. The vancomycin regimens were followed with twice daily oral cephalexin. Clinical cure was found in 76% of Oritavancin patients and 80% of vancomycin cephalexin patients. A second trial was almost identical, but it just dosed Oritavancin at an even 200 milligrams every day, and the clinical cure was found in 78.6% of Oritavancin patients and 76.2% of vancomycin patients. So Oritavancin was shown to be non-inferior to vancomycin in the treatment of skin infections. And then what they found was that the average duration of treatment was shorter with Oritavancin. Those patients averaged needing 5.5 days of treatment, while the vancomycin patients required 11 to 12 days of treatment. And then the SOLO 1 trial looked at a single dose of Oritavancin, and they found that it was non-inferior to twice daily vancomycin given for 7 to 10 days for the treatment of acute bacterial skin infections caused by gram-positive pathogens. Eligible patients were over 18 years old with a diagnosis of acute bacterial skin infection caused by a suspected or confirmed gram-positive pathogen and required at least 7 days of IV therapy. The primary endpoint was a composite outcome that comprised of the cessation of spreading or a reduction in the size of the baseline lesion, the absence of fever, and the absence of a need for rescue antibiotic medication. The secondary endpoints were clinical cure and a decrease in lesion area of 20% or more from baseline. The infection groups were balanced in the Oritavancin and vancomycin groups, with approximately 50% having cellulitis, 30% having abscess, and 20% having wound infection. The non-inferiority margin was a difference in outcomes of less than 10%. And all of the endpoints demonstrated non-inferiority, with the primary composite endpoint 82.3% with Oritavancin, 78.9% vancomycin. The clinical cure endpoint 79.6% Oritavancin, 80% vancomycin, and the endpoint of a reduction in lesion size of 20% or more, 86.9% Oritavancin, 82.9% vancomycin. And then obviously the Oritavancin was only given one time, and the average duration of treatment with vancomycin was about 8 days. Limitations include concern for extended illness if the patient has a serious reaction to Oritavancin. This is doubtful, but treatment experience with Oritavancin is limited, so it's unknown whether the potential for this could occur. Also, the inability to de-escalate antibiotic therapy once MRSA has been ruled out could result in increased microbial resistance. You can always de-escalate to less potent agent with vancomycin, but with Oritavancin, it's going to be in the body for over 10 days. Another study examined the use of Oritavancin in a human gut model inoculated with C. diff. They found that short 4-day courses of therapy with Oritavancin and vancomycin effectively treated C. diff infections. However, recurrence was found in the vancomycin group, perhaps providing evidence of Oritavancin activity against C. diff spores as well. The researchers designed this study based on the assumption that a shorter course of antibiotic therapy would interfere with the normal gut flora less, thereby decreasing C. diff recurrence rates. Oritavancin lowered spore counts to an undetectable level during the experiment. Vancomycin considerably lowered spore counts, but there were still some sporadic spores detected throughout the experiment. And then C. diff spores were undetectable until 19 days after cessation of vancomycin treatment, at which time C. diff infection recurred. The 4-day course of both antibiotics showed minimal effects on the gut flora, which was the goal. And then Oritavancin reduced toxin levels more rapidly and was more effective against spores. So it's possible that in the future we could see a 4-day dosing regimen of Oritavancin or some modification thereof as a viable option for the treatment of patients with C. diff. But it is not approved for that at this point. 2 open-label pharmacokinetic studies did not find any serious adverse effects associated with Oritavancin. Most common adverse effects are headache, dizziness, and nausea, vomiting, and diarrhea. The frequency of these side effects was found to be comparable to vancomycin. Abscesses have been noted in 3.8% of Oritavancin patients and 2.3% of vancomycin patients. And due to its long half-life, a severe allergic reaction to Oritavancin could be delayed, but such a reaction has not been found to occur so far. It has not been evaluated in pregnant or lactating women, and it is not significantly metabolized by the liver nor primarily eliminated by the kidneys, so it may not be necessary for adjustments for patients with renal impairment or hepatic impairment. So that would be a nice feature. When possible, it is good to avoid concurrent use of Oritavancin with warfarin. The co-administration may increase the risk of bleeding. In a drug-drug interaction study, Oritavancin was found to inhibit the CYP2C9 metabolism of warfarin, resulting in a 31% increase in the exposure to warfarin. In addition, Oritavancin interferes with some coagulation tests. The prothrombin time and INR are artificially prolonged for up to 24 hours after Oritavancin dosing, making the monitoring of warfarin unreliable during this time. So if these drugs must be administered together, it's important to frequently monitor the patient for signs of bleeding, since the INR test will be faulty. And in summary, Oritavancin is the only glycopeptide with activity against both vancomycin A and vancomycin B phenotype-resistant enterococci. Its bactericidal activity is more rapid than that of vancomycin. This drug may offer decreased administration time for nurses, a lack of drug interactions, no need for dose adjustments in renal or hepatic impairment, and no need for lab monitoring. The long half-life opens up the possibility of possibly treating skin infections on an outpatient basis without the need for lab monitoring or an indwelling catheter, which would reduce costs and reduce the length of hospital stays. And then its use in infections other than skin infections is unknown, but research is being conducted on that, and more research will be required.
Good. So 2 viable options here for acute bacterial skin and soft tissue infections. Now, remind me again, with both of these drugs and their primary trials, we were looking at sensitive pathogens. So the pathogens had to be sensitive to vancomycin as well. So we don't really have any clinical data, in vivo data, looking at resistant pathogens to vancomycin at this time with both of these agents, right? It's more in vitro data that we say that there may be some effectiveness there, but haven't seen that clinical data yet.
Yes.
And then both of these drugs approved underneath the new FDA requirements for how drugs are approved for acute bacterial skin and soft tissue infections. It's that early response mechanism of just showing no spread of the infection, a reduction of fever at 48 to 72 hours, and then they had secondary endpoints of actual reduction of lesion area. And both of these shown to be non-inferior to vancomycin. I think the Oritavancin component about INR is certainly something that we want to keep in mind as clinicians, and specifically within pharmacy, to note that, one, you've got going to have reduced metabolism of INR, so increased warfarin exposure, and then additionally we're not going to be able to measure what that INR is. Now, same thing for the APTT, that's also going to be altered, but that's up to 48 hours because these are both phospholipid-based reagents. So if you got someone on a heparin drip, I'm not going to be able to monitor that as well. What you'll have to do is use a factor 10A level to check for that because it's not phospholipid-based. So great, very good options. Concerns with price, concerns with if there is a drug reaction with these. Both of these can also cause the red man syndrome, correct? So we can still have that infusion-related insult where there's erythema, pruritus of the upper extremity associated with the infusion. So we just need to back down the infusion again. 30 minutes for Dalbavancin,
Yes.
3 hours for Oritavancin, I believe. So there you go. Anything else we're missing? Talking about with the lipoglycopeptides? No. All right. Well, there's some information about these guys. We'll have more information as use occurs and we get case reports, some observational studies. Certainly be interesting to see how these start to be used as we move into the future. So again, thank you for joining us, and we will see you in the next edition of Journal Clubs with Dr. Wamwell, right? Okay.
Right.
Right.